In the first session, what we did, we defined heart failure. We're we're doing heart failure with reduced ejection fraction. As we had mentioned that the current definition or the current nomenclature is heart failure with reduced ejection fraction and heart failure with preserved ejection fraction. So those are the terms that are currently used to describe heart failure. And we're presently doing heart failure with reduced ejection fraction, and later on we'll do heart failure with preserved ejection fraction. So the heart failure with reduced ejection fraction, we used to call that systolic heart failure, and or dilated cardiomyopathy, that type of thing. Uh, so we had basically went over the definition for heart failure, which is the inability of the heart to pump blood to meet the needs of the body. So the heart is not supplying the body with sufficient blood. And, the etiology, numerous, but we're not going to discuss the different cause. When you say heart failure with reduced ejection fraction, you're talking about ejection fraction less than or equal to 40%. So you have to be clear on that definition. We also went over the epidemiology of heart failure. Heart failure is a disease of aging. Okay, the proportion of individuals who are older, with heart failure is greater than individuals who are younger. So the older you get, the greater your chance of developing heart failure. We also look at the risk factors that predispose one to heart failure: hypertension, diabetes, obesity, and we sort of carved out um, the metabolic syndrome, because that's one of the category of individuals who will develop heart failure. And if you remember, the metabolic syndrome comprise of abdominal adiposity, okay, a fat waistline or a big waistline, increased triglycerides or hypertriglyceridemia, hypertension, a low HDL, and fasting hyperglycemia. So if you have three out of those five uh, categories, then that puts you into the metabolic syndrome, and that increases your risk of heart failure. Uh, we also look at the incidence and the prevalence and incidence of heart failure in the American population. Uh, Roughly about 5 million Americans suffer from heart failure. We also look at the 5-year mortality, which is about 50%. This is untreated. So the 5-year mortality, 50%. So it's a disease with a very high morbidity and mortality rate. And then we introduce the staging of heart failure. It's important to understand the staging. It's relatively new, and we had mentioned that stage A and stage B, those individuals are asymptomatic. Stage A and stage B heart failure patients are asymptomatic. The stage A patient only have risk factors. So the stage A patients, individuals only have risk factors. Uh, and then your stage B have structural heart disease, but they're asymptomatic. So both the stage A and the stage B uh, individuals are asymptomatic. And then your stage C are those are patients who previously had heart failure are currently in heart failure. And then the stage D is the refractory individual, patient who is always in the hospital, patients who is on LV assist, or they're set up for cardiac transplant. Um, we also had we had married the grading system with the New York Heart Association classification. So it's good to go over that so you can get an appreciation of remember stage A and B patients are asymptomatic, so you can't put them in essentially you can't put them in the New York Heart Association classification because your class 1 individuals are patients who have uh, well, stage 1 is relatively asymptomatic, so you can put your grade your stage A and B in the New York Heart Association class 1. But when you start talking about class 2 and class 3, then is either stage C or D. So it's important for you to go over that. um, then it's very important to understand the concept of myocardial insult, because that is what triggers the heart to do all sort of crazy stuff. Okay, so the heart or the myocardium have to be insulted, and the insult can be just a heart attack, a viral myocarditis, or whatever the insult to the myocardium, and then that's going to trigger a series of change in the heart that give rise to heart failure. Okay, one of the big thing in once the heart is insulted, it undergoes what we call remodeling. So that was one of the big things that we discussed. Insult to the heart, whether it's a heart attack, a myocarditis, you name it, or it might be a valve which is leaking over a long period of time. The heart is going to respond to that insult. Okay, and one of the response that the heart is going to go through is what we call the remodeling. So LV remodeling, which is you get myocyte loss, myocyte elongation, and myocyte slippage, and then that's going to give rise to LV dilatation. The left ventricle is going to get dilated, and you're going to have hypertrophy. It's going to thicken, and you'll have increased diastolic wall stress. So the first thing to happen is insult to the LV or the myocardium. Then you have remodeling. So with remodeling, you have myocyte loss, elongation, slippage. The left ventricle is going to dilate, and you'll have some amount of hypertrophy. It's thickened as well, and increased diastolic wall stress. So that now leads us to insult and the insult to the heart, and then the heart undergoes remodeling, and then you have compensatory mechanism. So the body is always trying to right things to sort of make things better. So when the heart is insulted and you have LV remodeling, you're going to have decreased cardiac output. That's one of the main thing. Decreased cardiac output. The blood pressure is going to decrease. So the compensatory mechanism try to correct that decrease in the cardiac output. So because when the heart is insulted, there's a tendency for one of the main thing is to reduce the stroke volume and cardiac output. The function of the heart is going to be reduced. What is the function of the heart? To pump blood. Okay. Per beat, the heart is going to pump out a certain volume of blood. I will call that the stroke volume. The stroke volume times the heart rate give you the cardiac output. So when the heart is insulted, you're going to have decreased stroke volume, decreased cardiac output. So the compensatory mechanism try to correct this. And if you just look at the compensatory mechanism, you can have cardiac. So of course, because there's a tendency for the heart muscle is weak, right? So you're going to have increased stretch, you're going to have increased pressure in the LV cavity, and that's going to trigger the Frank-Starling mechanism. So the Frank-Starling mechanism is a compensator mechanism. So it's going to increase the contractility depending on the amount of stretch that it's subjected to, and that will sort of maintain the cardiac output to a certain point. There are certain vascular uh, compensator mechanism that comes into play, because one of the when you have decreased cardiac output, um, the vascular resistance tend to increase, and over time that increase. So initially, the increase in the vascular resistance is a good thing because it maintains the blood pressure. But long term, it's gonna cause the heart to fail more, because then the heart is gonna pump against this increased load. So over time, it's going to be bad. So the compensator mechanism, if you look in them, they are good initially, they are good acutely, but long term, they destroy the heart, and that's one of the problem with heart failure. The compensator mechanisms tend to worsen the disease state, so to speak. Then the next compensator mechanism is the autonomic nervous system. You commonly get increase in your sympathetic tone and a decrease in the parasympathetic tone. So, so there's a tendency for the heart rate to increase, and, for all the stuff that's going to decrease the heart rate to be removed. That is in order to maintain cardiac output, So, so that's another uh, compensator mechanism, which is important. Then um, you have the hormonal milieu, the renin, angiotensin, aldosterone system, which of course tries to maintain cardiac output and blood pressure. But over time, those things are bad. So we come to the current lecture today, which is biomarkers. So up until recent, we didn't really have much. Well, they were there. We just didn't pay much attention to these biomarkers of heart failure. So what are the biomarkers? So these are it can be hormones, it can be proteins that are increased in heart failure, and it gives us, it helps us to make the diagnosis of heart failure, and also it can tell us how bad the heart failure is. So it can give us it can prognosticate. Okay, so we use these markers to help with the diagnosis, not solely. So you should never use the biomarkers to solely diagnose, but they help in diagnosis, and they are very good in prognostication. Tell you how poorly that individual is going to do. So again, so the different compensator mechanism that we talk about gonna produce so-called biomarkers, and so we can divide them into myocardial stress and injury. Okay, because again, the myocardium, for you to develop heart failure, there have to be an insult to the heart. Okay, so you're going to get biomarkers related to the myocardial stress or injury itself. You get biomarkers related to the neurohormonal activation, the so-called renin, angiotensin, aldosterone system. You have biomarkers related to the remodeling process that the heart is undergoing, and then biomarkers related to comorbidities. So when you have heart failure, it puts strain on the kidneys and the liver and the hematologic system. So if you look at the kidneys, over time the kidneys gonna fail, and the liver will also fail as well. The worse once the disease progress. So the biomarkers that we have today are related to the compensator mechanism that occurs. And one of the main one is or so-called BNP or NT-proBNP. So what is this BNP? So when you have insult to the heart, okay, um, and you have damage to the myocardium, the LV wall is going to stretch. You're going to have increased pressure and volume, because that is how the heart is going to try and compensate for the reduced function, the so-called Frank-Starling mechanism, okay, trying to maintain cardiac output. And by this increased pressure and increased volume inside the LV, you're going to get it's going to induce the BNP gene transcription. Okay, so you're going to get an inducer of BNP gene transcription, and also pro-BNP is going to be cleaved to BNP. It's brain natriuretic peptide. Okay, so because of the increased pressure and stretch of the LV, there's gene is gonna be modified to give you these pro BNP and NT pro BNP. Okay, the pro BNP is further broken down to BNP and NT pro BNP. So that's brain natriuretic peptide. So what we are saying is that you have insult to the heart. The heart tried to compensate for this insult. Okay, so the Frank-Starling mechanism is going to come into play. Okay, so for the heart to maintain any type of function, there's going to be increased pressure, there's going to be increased volume, because that's how the heart is going to now try to increase the contractility. And by increasing the pressure and volume in the LV, you're going to have certain change in the genetic structure, and you're going to get pro BNP, and that is cleaved to BNP and NT pro BNP. You can also, if the injury to the myocardium is significant, you'll also get a leak of troponins. Okay, all right. So it depends on how significant the injury to the myocardium. You can also get leakage of troponins. Okay, so just let us concentrate on the BNP and the pro BNP, or the BNP and the NT pro BNP, because those are the important ones. So what is BNP? I would say that BNP is the brain natriuretic peptide. Okay, and so we went over how it is induced and how it's produced. So BNP, what BNP does, so remember, these are compensatory mechanism. It's not, they are induced and they're produced to try and maintain the heart function. So BNP causes natriuresis, so you tend to lose sodium. Because one of the problem with congestive heart failure is fluid. You tend to retain fluid. So by causing natriuresis, you're going to lose sodium and water, and that you can also get loss of free water diuresis. So BNP causes natriuresis, the loss of sodium, and diuresis, you're just losing fluid, okay, through the kidneys, okay. So that's good, you know. So you would think that over time, you know, this is something good. BNP also causes vasodilatation because remember what we said. One of the When the heart is insulted and you have decreased cardiac output, you get increased vascular resistance as a compensator mechanism. So if the BNP is going to now cause vasodilatation, that will reduce the vascular resistance. So that's good. The BNP also cause inhibition of the renin and aldosterone. Okay, so aldosterone, you know, remember when you develop heart failure, you're going to stimulate that renin angiotensin aldosterone system, and that's going to try to maintain. You're going to retain salt and water. Okay, again, it's a compensator mechanism because you know the body realized that there is not enough blood coming out of the heart. So whatever it can do, it's going to try to maintain cardiac output and blood pressure. So you're going to stimulate the renin angiotensin aldosterone system. That is a compensator mechanism. But what we're telling you that this BNP that is produced cause inhibition of the renin aldosterone system, which is good. So you see, BNP is causing a lot. BNP does a lot of good stuff. It also causes inhibition of fibrosis, and then as you know, fibrosis is one of the after you get insult and you go through all those things, you get fibrosis of the myocardium. So fibrosis is one of the problem with cardiac insult. So BNP does a lot of good things. Okay, it is induced once there's increased volume and pressure in the LV. All right, so we say it causes natriuresis, diuresis, vasodilatation, inhibition of the renin aldosterone system, and inhibition of fibrosis. Now, this BNP, brain natriuretic peptide, it's removed from the circulation. So you develop heart failure, increase volume and pressure in the LV, you have an outpouring of BNP. So it is removed from the circulation by receptor mediated mechanism. So it attached to certain receptors and it is destroyed. Or you can have degradation by the neural endopeptidases, the so-called neprilysin, okay, the so-called neprilysin. So you need to pay special attention to this because there's a relative new medication to inhibit this neural endopeptidase, okay, the so-called inhibition of the neprilysin system, okay, because since BNP does so many good things, if you can prevent the breakdown of this BNP, then you can get the beneficial stuff from the BNP. So we have a medication now which can inhibit the degradation by the neural endopeptidases. You can also remove the BNP passively by other organs, such as the kidneys. Okay, BNP, the half-life of BNP is about 20 minutes, and then the NT-proBNP is about 120 minutes, so it's much longer. Okay, so again, BNP is produced when there's an insult to the heart, increased volume and pressure. BNP does a lot of good things, which counteracts the heart failure, but it is removed from the circulation, okay, via receptor-mediated mechanism, degradation by neural endopeptidases, this so-called neprilysin system, and then passively cleared by other organs such as the kidneys. The diagnostic evaluation of acute heart failure, we use the BNP and NT-proBNP because remember it is relatively sensitive. Once you have increased stretch in the LV, increased pressure in the LV, you're going to the pro BNP is going to be cleaved to your BNP and NT pro BNP. So circulating levels are quite low in normal individuals. So in a normal person, the circulating levels are very, very low because in order to induce the BNP, you need to get increased pressure, increased volume in the LV. Levels are increased in heart failure, or levels are high in heart failure. And one of the cutoff for BNP is greater than 100 picogram per ml. So this is a rough cutoff. So, if your BNP is very low and the patients have shortness of breath, you can probably say, fairly accurately that the patient does not have heart failure. Okay? So to diagnose acute heart failure, the accuracy is about 85%. That is if the BNP is greater than 100 picogram per ml. That diagnostic accuracy for acute heart failure is about 85%. It is also strongly predictive of heart failure outperforming clinical criteria. What we are saying is that, when I went to medical school, we used to have these clinicians who pride themselves on being super clinicians, but once we test them, we realize that they were really bluffing and they're really guessing and stuff like that. If you use your clinical acumen to the best of your ability and you take your grade history, physical examination, and whatever else, the BNP still outperform the clinical criteria in making the diagnosis of heart failure. So you should use it in conjunction with your history and your physical and stuff like that. So the NT-proBNP is fairly similar to the BNP. Okay, there was the PRIDE's trial, which they look at the pro-BNP investigation of dyspnea in the emergency department, the so-called PRIDE. And what they found was that the NT-proBNP cutoff was approximately 900 picograms per ml. But you can further it is the N terminal. So you as the N terminal. We talk about N and a C terminal. So it's how we describe the portion of if you have a long chain, we can talk about the N terminal and stuff like that. So that's what that stands for. So the NT-proBNP cutoff is approximately 900 picograms, but you can further age classify it. You can further age classify it. For the cutoff for someone who is less than age 50 is about 450 picograms per ml, and someone 50 to 75, that's about 900. But you can see, the whole individual, the patients who are older, the cutoff is much higher. So what we're saying is that, someone who is a older patient, you need a much higher NT-proBNP or even the BNP to make that diagnosis. Okay, so the cutoff level increases with age. All right. So how should we use the BNP and the NT-proBNP? It is best used to support your clinical judgment. So someone coming with shortness of breath. So you're not going to rely solely on your BNP or your NT-proBNP. Okay, you're gonna still do your history physical and put everything together. You're gonna get these levels, and of course, you have to use the age of the patient. If the patient is an older individual, then you're going to use a much larger cutoff. Okay. You also have to exclude the diagnosis when it's very low. So if they're coming with shortness of breath and stuff, and it's very low, then it's the negative predictive value is very high. So if a low level almost exclude the diagnosis of heart failure. Okay, so these are just put in a table form um, for the BNP. Okay, to exclude acute heart failure. If the BNP is between 30 and 50 picograms, to exclude it's about 97% sensitivity, 62% specific, and the positive predictive value, negative predictive value. So negative predictive value is 96%. So for a low BNP, you can almost, categorically say that the patient does not have heart failure. So the negative predictive value is pretty high. And then for the NT-proBNP, again, if it's less than 300 picograms, negative predictive value is 99%. It's a sensitivity of 99%. So if it's negative, it's good. If it's high, then you have to put the whole picture together. Okay. Um, And again, as we had mentioned before, it is age sensitive, especially both of them are age sensitive. The older the patient, you have to use higher levels. Okay. Um, so there are some caveats that you need to know. As we say, it's very sensitive. The accuracy is pretty good, but there are other conditions that can cause elevation of the BNP or the NT-proBNP. There are other things that can cause that. Acute coronary syndrome, myocarditis, valvular heart disease, hypertrophic cardiomyopathy, cardiotoxic toxic drugs, atrial fibrillation, atrial flutter. So patient coming with atrial fibrillation flutter, you know, be cautious. Don't go around giving diuretics to these patients. RV dysfunction in the setting of pulmonary disease, advanced age. So we went over that in a little detail. You know, older individuals tend to have higher levels. So don't know what is the cutoff for what the age of the patient that you're seeing. Um, so you don't go ahead and just treat the patient for heart failure. But important, so renal dysfunction. So these are important caveats. Age, renal dysfunction. So if someone has renal impairment, you have to uh, analyze or use the BNP very cautiously. All right, patient with strokes, any critical illness, high output states, and then the neprilysin inhibitors. Okay, so we start using these neprilysin inhibitors. So uh, if your patient is taking a neprilysin inhibitor, you probably should not use BNP and NT-proBNP. Okay, but the important caveat is the age, renal dysfunction. I mean, patient is uh, sick, critically ill. You know, the levels may be elevated, and then of course neprilysin inhibitors. So we start using these medications now. So be careful. So the condition associated with lower levels than expected. Um, Patients who present with heart failure would preserve EF. So patients with heart failure with reduced EF tend to have higher BNP and NT-proBNP levels. So that's a testable um, question. I can see them putting that on the exam. Okay, obesity, because there's a suppression of synthesis or release. Okay, the BNP. So how can we use BNP and NT-proBNP for prognosis and treatment? So it's commonly patient come into the hospital and some physicians use these BNP. They'll get them daily. You know, they'll get them daily and follow the progress of the patients. Is that the right thing to do? Well, the ADHERE trial or registry, which stands for Acute Decompensated Heart Failure National Registry, the ADHERE, um, they look at admission BNP. So when the patient is admitted to the hospital with a heart failure, they get the BNP, and what they found was that BNP greater than 1730 picograms per ml was associated with a 2.23 fold increase in hospital mortality. So high BNP level is associated with an increase in hospital mortality, increase in patients dying. Um, and then the admission NT-proBNP greater than 986 picograms per ml was associated almost a threefold increase in 1 year mortality. So what we're saying is that increased levels of these biomarkers portends a poor prognosis. Okay, and if you look at the optimized heart failure trial, which stands for Organized Program to Initiate Life-Saving Treatment in Hospitalized Patient Heart Failure, optimized. The discharge BNP. So just prior to discharge, you're going to get a BNP. It was found to be the most important predictor for 1 year mortality or rehospitalization. But the bottom line is that BNP, elevated BNP, the higher the level, it's the worse the prognosis then. Okay, um, and then you look at the Valsart and heart failure trial. In chronic heart failure, increase in the NT-proBNP was associated with a 1.7-fold increase in the risk of mortality. And treatment that improves mortality and morbidity in heart failure reduce these natriuretic peptide level. So if you use therapy that improve mortality and morbidity, then you're going to get reduction in these BNP and NT-proBNP level. So the doctor who gets daily BNP, it's an expensive way to treat the patient, but studies have shown that it's not a bad thing to do. Okay, because if you're using therapy that reduced the level, then we know that that's going to improve mortality and morbidity. So it's not a bad thing. It's an expensive thing to do, but it's not a bad thing to do. So what are the guidelines? So, we have a whole, we say a lot of stuff, but we have guidelines. We have certain bodies that help us to decide what to do. And the American College of Cardiology Foundation, the American Heart Association guideline states that BNP and NT-proBNP is class 1A. Okay, so for diagnosis and prognosis, it's class 1A. So in 2017, if you have a patient admitted with suspected heart failure, you should get a BNP and an NT-proBNP. It's a class 1A, so it should be done. Okay, so in the United States, it's tantamount to malpractice if it's not done. So for the diagnosis and for prognostication. For just guiding heart failure management in chronic heart failure, it's a class 2A. So the doctor who have the patient in the hospital or outpatient and getting serial BNP, it's not the best. It's not a class 1A. It's a 2A. So, there are evidence that it can be done. It's expensive. I wouldn't recommend it, but, it's okay. And then for guiding heart failure management in the acute heart failure, it's a class 2B. So, it can be done. And it is done. A lot of physicians do it. All right. So remember when we said that if the insult is significant, you can have damage to the myocardium and you can have the leakage of these troponins, T and high. But you should also remember that one of the insults in someone who presents with heart failure is a heart attack. So you have to get troponins because you don't know if it's the heart attack which insulted the heart and caused the heart failure. So, troponin, T and I are frequently detected. And when we look at the HADIA registry, there was about 6.2% of patients with acute heart failure that had elevated troponins. Okay? And when we say elevated troponins, we're talking about a troponin I greater than 1, troponin T greater than 0.1. And they're associated with worse in-hospital mortality. So, common exam question, is troponin INT associated with worse in-hospital mortality? Yes, it is. So if there's elevated troponin, bad news. Elevated BNP, proBNP, bad news. The higher the level, bad news. So that's basically it. So looking at the HADIA registry again, in chronic heart failure individual, 92% of patients were found to have measurable elevated. This is high sensitivity troponin T. So it's very sensitive, and the high sensitivity troponin T greater than 0.012 was closely linked with poor clinical outcomes. The bottom line, if the troponin is elevated, poor worse outcome. Okay. So for the guidelines again, so everything we talk about guidelines. So it's a class 1 troponin TNI is a class 1 for prognosis and detection of acute MI. Okay, the patient comes in with heart failure. You don't know if the insult is due to an acute heart attack. So you have to get it. It's a class 1. So we look at biomarkers, related to insult, the increased pressure and volume. We can look at biomarkers related to the neurohormonal activation. So remember, this is one of the compensatory stuff that goes on when the patient develops heart failure. You have an increase in the sympathetic tone and a reduction in the parasympathetic tone. Okay, so when you have cardiac injury, when you have insult to the heart, you have activation of biologically active proteins, we know that, which attempt to compensate for the reduced myocardial function. That's why we call it compensatory mechanism, Prolonged activation of these compensatory mechanisms, however, leads to maladaptive effects and progression of the heart failure. So one of the important thing about heart failure is that initially in the acute setting, these compensatory mechanisms are beneficial. Keep the patient, breathing okay, cardiac output near normal. But long term, over a long period of time, it destroys the heart. You get progression of the heart failure. Okay, so that is why you have to, especially the neurohormonal activation, you have to blunt it, and you have to use approach to lower or to lessen these neurohormonal activation. So one of the things that happens is this MR Pro ADM, which stands for Mid Regional Pro Andromedulin. So adrenomedulin. So what happens is when you have activation of the sympathetic nervous system. So remember what we said, as a compensatory mechanism, you're going to get increase in sympathetic tone and a decrease in the parasympathetic tone. When you have activation of the sympathetic nervous system, you produce this mid-regional pro-ADM, which is a precursor of this adrenomedulin. And adrenomedulin is a potent vasodilator and inotropic, and have inotropic properties as well. So this is produced in response to the heart failure because it's just trying to help. It's trying to help, but over a long term, it's going to destroy the heart. Okay? So activation of the sympathetic nervous system, you get the production of these mid-regional pro-ADM, which is a precursor of adrenomedulin. Adrenomedulin does some good things. It causes vasodilatation, and it has inotropic properties, which when we say inotropic properties, it causes the heart to increase its contractility, which is what you want. Remember, when you have insult to the heart, reduction in cardiac function, you're going to get increase in the systemic vascular resistance. So now if you have something that causes vasodilatation, then you're going to reduce the vascular resistance. And one of the problems with these insults and the heart failure, the heart muscle is weak. So if you have something that's going to increase the contractility, that's what you want. So, but you can measure these mid-regional pro-ADM, okay, which is a marker of the neurohormonal activation. You can measure this. It is elevated in acute and chronic heart failure. It is a strong predictor of clinical outcomes. Okay, so again, the higher the level, the worse the patient is going to do. All right. There's also another neurohormonal if you want to call it protein that is produced, is what we call copeptin. So this is the stable C-terminal propeptide fragment of arginine vasopressin. So again, so you have a C-terminal and you have an N-terminal. It just tells you what portion of, if you have a long chain polypeptide or protein, you can say where a certain portion of it is by using the C-terminal and the N-terminal. So the copeptin is the stable C-terminal propeptide fragment of arginine vasopressin, AVP. Okay. Now, AVP regulates free water clearance and plasma osmolality by the kidney. So AVP does some good things. So the body's going to produce this when the patient have heart failure, okay, because it's going to regulate free water clearance and plasma. But you can measure how much of this AVP, arginine vasopressin, that is produced by looking at copeptin. I would say that copeptin is just a stable C-terminal portion of the propeptide. So there's the BAC trial, which stand for biomarkers in acute heart failure, show that elevated copeptin level was strongly predictive of mortality. So you can see that once you have increase in these biomarkers, it's telling you that the patient is going to do poorly. So, and then hyponatremia and elevated copeptin level was more predictive. They were more predictive. All right. So, what about biomarkers for myocardial remodeling? So remember, remodeling, you have an insult. Once you have an insult, then you're going to get myocyte loss, so-called apoptosis. You're going to get myocyte elongation. You're going to get slippage, and then you get LV dilatation and hypertrophy. That's what we call remodeling, okay? That's going to change the size and the shape of the LV. So remodeling is bad, okay? And of course, remodeling leads to progressive myocardial dysfunction. So, especially acute myocardial infarction. Once the patient have an acute myocardial infarction, we throw a ton of medicine on the patient. And the reason for that is, one of the reasons for that is to reduce myocardial remodeling, because remodeling is bad. It leads to heart failure. So there are a few medications that can reduce remodeling: beta blockers, ACE inhibitors, ARBs. Okay. Okay. So there's still another biomarker, and that's a biomarker of myocardial remodeling. We call it the ST2 gene. The ST2 gene, which is strongly induced in the setting of cardiomyocyte or cardiac fibroblast stretch. Okay, it is strongly induced in this setting, and it is closely involved in hypertrophy, fibrosis, and anti-remodeling properties. So the ST2 gene is a marker of remodeling. Okay, increasing concentration associated with clinical outcome in heart failure. So again, these markers are sort of predicted. Once they're increased and the level is increasing, it suggests that the patient is going to do poorly. However, the ST2 gene is not affected by age, renal function, or BMI. It is one of the strongest predictors of mortality at 30 days and 1 year. So it's a very sensitive marker, and it's associated with more than threefold risk in adverse outcomes. So the ST2 gene is most powerful biomarker predictor of risk. It is superior to galectin-3 in chronic heart failure. So galectin-3 is another biomarker. Okay. In lower risk population, elevated level predict future development of heart failure. So, patients who, you just take the general population, they don't have any risk factor for heart failure. If they have this ST2 gene, then it tells you that in the future they may develop heart failure. Again, so galectin-3 is another myocardial remodeling biomarker, and it's involved in the inflammatory pathways, elevated in acute and chronic heart failure. So what does the guideline states then? So the guideline states that ST2 and galectin-3, they're class 2B for chronic and acute heart failure. So you don't have to do them. BNP, pro-BNP, class 1. And then your troponin, INT, class 1. You can get them. They may throw these in the exam at you, just see if you understand what's going on. But since it's a class 2B, they're not gonna feature it. Okay, they tend to bring class 1 indication, class 1 stuff. Um, so when you have heart failure, as again, heart failure is when the inability of the heart to pump sufficient blood throughout the body. The kidneys are very sensitive to decreased output. So because the heart is not pumping sufficient blood, the kidney is not going to get sufficient blood, and you're going to get acute kidney injury. You can also have liver dysfunction and hematologic dysfunction as well. And we have some markers to detect acute kidney injury. Okay, the so-called NGAL, which is a neutrophil gelatinase associated lipocalin, NGAL. So these are biomarkers for acute kidney injury. Also, the KIM1, which is the kidney injury molecule, so another marker, and then the NAG, NAG, which is the N-acetyl B glucosamidase. So these are, so there are markers for acute kidney injury. But in clinical practice, you get to be on creatinine. If they're going up, then you know that the kidneys is involved. And then for the liver, we use interleukin 18. You can use liver type fatty acid binding protein. So we're gonna, it's a lot of stuff we throw your way. People who are doing the exam, they're gonna give you these things. These are the boring stuff, but you need to know it a little bit. What you should be doing is, don't just study them in an isolated fashion. Sort of put it together. Of course, you have the heart being insulted, cardiac dysfunction, compensatory mechanisms, and just try and tie up everything. Okay? So don't just try to study it in isolation.